Assalamu alaikum. Today is our third lecture on adrenal disorders, and this would be our last lecture on endocrines, and then we are finished with the allotted topics, and we'll we'll be having a test on endocrine disorders and diabetes in next lecture. So to start our lecture, we'll talking about adrenal medulla. A medulla, as opposed to the cortex, is actually an extension of a sympathetic nervous system, or it can be called as where cortex is an endocrine gland, the medulla is modified sympathetic ganglion. So from the anterior spinal cord, these pre-ganglionic sympathetic neurons, they end up in the adrenal medulla, and there this chromaffin cells over there, they are actually a modified post-ganglionic sympathetic neuron, and then these neurons release epinephrine, and this which is a neurohormone, and main target of its action is blood vessels and then to other target tissues as well, and where it causes not only the vasoconstriction but the epinephrine acting onto the heart may lead down to increased contractility of the heart as well as increase in the heart rate. So our first case is a 22-year-old male who presents with the complaints of severe headache, which is off and on, and along with that he also experiences palpitation, sweating, and this happens all of a sudden while he is carrying out his routine daily activities. He also complains of having a sense of impending doom or generalized weakness, and many times his friends have noticed that he's unexpectedly or unusually trembling or having tremors of his hands. His co-workers also noticed that he often gets marked blushing of his face during such episodes. He was diagnosed hypertensive 1 year ago and is using at the moment 4 antihypertensive drugs, but his blood pressure is not really on target. Now, the noticeable things in this scenario are a very young person, 22-year-old, having hypertension, which is resistant to treatment despite 3 or 4 antihypertensives being used, and there are a lot of sympathetic overactivity symptoms in the form of palpitation, sweating, tremors, and headache. So, what do we think? Further extension of the examination, his blood pressure was recorded 210 over 140 millimeter of mercury. His pulse was 92 per minute regular. He was afebrile. There was slight pallor. There were tremors present in the outstretched hands, and some of the findings which are noticeable on his general scanning or general examination included this one. There was patches of this coffee colored patches over the back of the chest and over the front, and these are called PHEO spots. Incidentally, his mother was also examined, and that lady had neurofibromatosis type 1 all over the back of his chest, and one of his sister also had these PHEO spots. So there is something in common to sister, this patient, and his mother, and this linkage probably have to be kept in mind when we make a diagnosis. His hemoglobin was normal. There was slight leukocytosis. Sodium was normal, 130 milliequivalent per liter. His random blood sugar was high, which was 200 milligram per deciliters, and the normal thyroid function and ECG and echocardiographic finding were all within normal range. So what's the diagnosis? Again, we summarize this gentleman, young person with the severe hypertension, episodic spells of accelerated hypertension with tachycardia, with palpitation, a lot of sweating and all those sometime happening in episodes, and the evidence of this neurofibromatosis in mother and café spots in patient as well as in one of his sisters. The diagnosis is pheochromocytoma. What pheochromocytoma is? It's rare but fatal catecholamine producing tumor. Rare in incidence. There are only 2 to 8 patients reported per million population in a year. It accounts for 5% of the patients with adrenal incidentalloma. By incidentalloma, I mean that by just incidentally you find a mass or tumor or a growth in adrenal on a routine scanning, whereas the patient usually don't have any symptoms. There's an interesting rule of 10 about pheochromocytoma, that it is not always from the adrenal glands. Right? 10% of these sympathetic overactive say, tissue can be present in extra adrenal parts as well. And then when in adrenal, they can, in 10% of patients, they can be in bilateral. Around 10% of patients do have familial incidence of or occurrence of pheochromocytoma, and of the total number of adrenal tumors which are linked with the pheochromocytoma, 10% of them may be malignant. And then they not only just produce catecholamines, they can also secrete dopamine, another sympathetic or adrenergic say hormone or chemical, and they can sometimes produce adrenocorticotropic hormone, parathormone, calcitonin, and sometimes vasoactive intestinal peptides may also be produced. Pheochromocytoma have been associated with at least 3 different syndromes, namely von Hippel-Lindau syndrome, multiple endocrine neoplasia type 2 or MAN2, or neurofibromatosis type 1. There are at least 10 genes which have been identified as sites of mutation which lead to pheochromocytoma. It's quite rare, right? So if you talk of hypertension alone, maybe 1 in 1,000 to maybe 1 in 10,000 of the hypertensive may have say pheochromocytoma as cause of their hypertension, and when the hypertensive were screened, only 0.5% of those screened had say pheochromocytoma in hypertensive population. It happens equally in men and women. The most common age of occurrence is between 3rd to 5th decades. Although it's rare, but you might have to investigate for its occurrence in hypertensive patient particularly, especially if they have sign of symptoms as our patient had, like frequent headaches or flushing or palpitation, or if they present with severe or accelerated hypertension, or in a hypertensive crisis with a blood pressure of in excess of 200 and 110, or if their hypertension is refractory to treatment and despite 3 drugs being used, the blood pressure is not under control. You think of a secondary cause of hypertension, and the first one to think is possibility of pheochromocytoma. And similarly, if hypertension present in a very young or a very old patient, so whenever there you have a hypertension diagnosed in less than 20 years of age, or it occurs for the first time after 50 years of age, you think of secondary cause of hypertension, including pheochromocytomas. Sometimes you have to investigate, as we already described, that incidentally on imaging, on ultrasound or some scanning, you find a tumor in the adrenal, and you want to ascertain that whether this tumor is likely to be pheochromocytoma or any other adrenal tumor for that matter. The signs and symptoms can be easily remembered through this mnemonics in the form of blood pressure, there are 5 P's. Pressure is for hypertension. 90% of the patients do have hypertension. Pain, particularly the headache, is experienced by 80% of the people. Perspiration, palpitation, pallor, and paroxysm are, say, respectively seen in 71, 64, and 42% of the patients. The classical triad of pain, which is headache, perspiration, and palpitations, is usually described in patient with pheochromocytoma. If any of them is not present, this actually can be considered as that it excludes the diagnosis of pheochromocytoma clinically, and this is from a study which was done on almost 21,000 patients. The biochemical testing is that the end product of this is nephrine, epinephrine, or metanephrine, and plasma fractionated free metanephrine levels would be elevated in patients with pheochromocytomas. These can be checked either in plasma or maybe in the urine. This metanephrines may be checked. Sometimes in serum chromogranin A, since this is from the chromophene tissue, that can be tested or checked in blood. Clonidine suppression test, that by giving clonidine there should be a decrease in level of metanephrines, that can be done. Similarly, vinyl mandelic acid is another say metabolite of catecholamines, and its urinary levels can be a marker for presence of or increased production of catecholamines in the body. The primary source may be adrenals. Some additional lab abnormalities like erythrocytosis, leukocytosis, and hyperglycemia, as our patient showed, may also be observed. Some patient may have, as said, sometime it may produce, say, parathormone or maybe sometime calcitonin. So hyper or hypocalcemia or raised DSR may be associated in some patients. The level of catecholamine production does depend upon physical and emotional stress. So in patients who are under some kind of physical or emotional stress, they may have an elevated catecholamine levels, and sometimes false positives may be observed. Sleep apnea again leads on to increased release of sympathetic hormones or epinephrine and norepinephrine. So that can also be misleading, and sometimes a patient may be misdiagnosed. Drugs like monoamine oxidase inhibitors, tricyclic antidepressants, beta blockers, amphetamine, levodopa or methyl dopa or labetalol, buspirone or phenoxybenzamine, they all can affect the level of catecholamines, and whenever you are requesting to the lab for the checking of either metanephrine or vinyl mandelic acids, you have to exclude that patient is not taking any of the listed drugs. Then once you have documented that the symptoms are classical and patient has an elevated vinyl mandelic acid either in the urine, or there is an elevated serum metanephrine levels, then you have to locate that from where this is originating. And the most likely origin is usually adrenal. And we said 10% may be extra adrenal as well, but the first organ to be looked for is adrenal. Adrenal can be seen through ultrasonography, but sometimes, since it's quite small, adenoma can be very much small in size and maybe missed on ultrasound. So CT and MRI of the abdomen are more appropriate investigations. Nuclear imaging using 123 meta-hydroxybenzyl guanidine would also locate the not only the adrenal but the even extra adrenal location of the tumor or mass. Post-emission tomography or scanning using 18 FDG PET scan can also be used to locate the primary tumor, and if there is a multiple or extra adenocytes, it can be picked up through this PET scanning. Somatostatin receptor imaging using 111 iodine labeled octreotide can also locate or say localize the tumor. This is an example of say CT scan of the abdomen. Look at this huge mass in the left part of the abdomen above the kidney. This is spleen, and this is definitely above the kidney level. This is one large adrenal mass shown. This is another example which is shown on the right side, and not only this but the T2 weighted images does have say more easily localizing this tumor. The tumor treatment of this PHEOCHROMOCYTOMA is surgical. It's treatment of choice. For it can be proceeded with through laparoscopic adrenalectomy, which is more and more popular and more easy to perform, and then sometimes you have to go for an open laparotomy. But careful preoperative management to control the blood pressure and correct the fluid volume and prevent intraoperative hypertensive crisis is the mainstay of treatment, because when you operate on these patients, when you handle this adrenal, there is a increased surge of release of these hormones, and patient on the table can go into an hypertensive crisis. And if their hypertension is not well managed or well controlled preoperatively, peroperative complications are quite high. The medical treatment would be indicated for initially, as we described, for preoperative management to control the blood pressure and making your patient fit for surgery. It would be required for acute hypertensive crisis, because most of these time these patients present in hypertensive crisis, and in between the crisis their blood pressure sometime may be normal, and sometime this medical therapy is indicated for as a primary therapy for metastatic pheochromocytoma, which is not amenable to surgery or cannot be operated upon. The interventions which can be done preoperatively in these patients is the use of adrenergic blocking drugs. The minipress or pyrazosine is the drug of choice. Similarly, beta blockers would decrease the heart rate and lower the force of contraction. And similarly, in diet, the diet should be high in vitamin and mineral calories. No caffeine, because caffeine leads on to say increased sympathetic activity and sometimes can push you into crisis, and sedatives. So the mainstay of treatment of pheochromocytoma would be adrenergic blockade through minipress, beta blockade through beta blocking agents like indrol or propranolol or atenolol, and through diet where you avoid caffeine. And sometimes, since there is a lot of anxiety and apprehension and there's something, so sometimes sedatives may also need to be given. Usually we have to, for a pre-operative preparation, combine both alpha and beta blockers. So phenoxybenzamine is say an alpha blocker. Then selective alpha 1 blocker like pyrazosine can be used, and then this, as I said, propranolol and labetalol are two examples of beta blockers. So you have a combination of that. You give phenoxybenzamine along with propranolol or pyrazosine along with labetalol. Metyrosine is another say agent which can be used for the treatment of hypertension or hypertensive crisis, and similarly calcium blockers like nicardipine can be used in certain set of patients. During surgery, we have to give Regatin and nepride, which is Regatin is antisymptomatic and nepride is vasodilator, and this is to avoid or prevent hypertensive crisis when this adrenal gland is handled with during surgery. Post-operatively, the most cases can stop all blood pressure medications. So this is one example where hypertension can be cured. In most of other cases or secondary, the essential hypertension, you only control the blood pressure, you cannot cure it. So this is one example where it can be cured. The other example of where cure can be achieved may be coarctation of aorta. And 74% of the patients were hypertension free after 5 years, and 45% were free even after 10 years. But then there was some recurrence, and possibly the primary tumor or some of the remnants of the tumor, they regrew and can lead on to hypertension again, or sometimes there may be some mets which might have been left behind. Usually post-operatively, you collect 24-hour urinary collection for VMA or metanephrines, so that you know that their level has dropped significantly post-operatively. This 24-hour urinary collection for metanephrines should be continued every year for 10 years, and should be and may be required for a lifelong follow-up. The complications of pheochromocytoma would be, of course, primarily the complication of hypertension or severe hypertension, which can lead on to left ventricular hypertrophy, left ventricular failure, or heart failure, or pulmonary edema. Accelerated hypertension can lead on to intracerebral bleed or hemorrhage, and particularly those with von Lindau-Happel syndrome, they are likely to have these complications. Catecholamine-induced cardiomyopathy can set in, and of course sometimes severe heart failure or cardiovascular collapse can. There is risk of sudden cardiac death due to cardiac arrhythmias because of this sympathetic overdrive, and some of these patients may for the first time present with adult respiratory distress syndrome, or as a in hypertensive crisis, and the risk of sudden blindness, CVA, is not very uncommon. If the tumor is found to be unresectable or it is malignant, then the mainstay of treatment, of course, is to control the sympathetic activity, and this can be done through alpha blockade, like selective alpha-1 blockers like prazosin, trazosine, doxazosine. Any one of them is the first line, as they have less side effect. And then you may have phenoxybenzamine, which is not selective but more complete alpha blockade, and does have some other untoward effects as well. This might have to be combined with beta blockers, and sometimes you have to go for other like calcium blockers and ACE inhibitors as well. There is some hope that this high dose of 131 MIBG indium octreotide can pick up this say metastatic tumors, and it may sensitize these tumors to carboplatinum or 5-fluorouracil, and this adjunct therapy can be considered for some selective patients. Pregnancy poses a special problem that diagnosis is made or confirmed with 24 urinary collections or with MRI. You can't go for any stimulation test. You can't go for MIBG in pregnant women. In first and second trimester, or when the pregnancy is less than 24 weeks, phenoxybenzamine, alpha blocker plus beta blocker can be administered and should be administered. Tumor should be resected as soon as possible laparoscopically. But in third trimester, phenoxybenzamine plus beta blocker, along with when fetus is large enough, this lady should deliver through cesarean section, and maybe this may be followed by, or maybe at the same time, there should be tumor resection done. Right. Now, our second case is a 16-year-old girl who was brought to medical outpatient department complaining of increased facial hair and acne. Her mother was concerned about her delayed menarche as well, and also that she was not having a very smart feminine figure. On her last visit to physician, she was told to watch her blood pressure, which was recorded 140/95. On examination, patient was having male type hair pattern along with ambiguous genitalia. Now, this is a case with the young female with hypertension and some virilization or some androgenic, say, characteristics developing in a young female. This is a case of congenital adrenal hyperplasia. This is a group of inherited autosomal recessive disorders in which a genetic defect could result in deficiency of an enzyme which is essential for synthesis of cortisol and at times aldosterone. So, when the enzyme which is responsible for cortisol and aldosterone is deficient, the whole pathway is diverted to more synthesis of mineralocorticoids and more synthesis of androgens. This is would lead on to the androgen excess. So this reduced cortisol secretion results from the absence of feedback pregeneration that lead on to increased ACTH to maintain this adequate cortisol, causing further adrenal hyperplasia. So there are several forms of congenital hyperplasia. The most common of them is 21-hydroxylase deficiency, and which is almost 90% of the cases of congenital adrenal hyperplasia are because of 21-hydroxylase deficiency. If you remember this pathways, that there was the primary, say, substrate for synthesis of hormones or cortisols and other adrenal hormone was cholesterol. It, under the effect of desmolase, was converted into pregnenolone, and under 17-alpha-hydroxylase it was converted into 17-hydroxypregnenolone. Under beta-hydroxylation, dehydrogenase was then converted into 17-hydroxyprogesterone, and 21-hydroxylase would lead on to the converting into 11-deoxycortisol, and then another hydroxylation at 11 position would then finally lead into cortisol. So this is the pathway which it takes on to synthesize the cortisol. If you block any one of this, either here or here, this would lead on to this pregnenolone being diverted to this pathway. And whatever here, and there is an excessive 17-hydroxypregnenolone undergoing, say, hormonal conversion, this would lead on to an increased androgens. And this would lead on to say, if this may be ambiguous genitalia, there would be hypertension. Sometimes there's maybe very lethal. There is a lot of salt wasting, and then these patients would be virilized and they would have high androgens. So the mainstay of this enzyme deficiency at the 21 hydroxylase deficiency or 11 beta hydroxylase deficiency would be that there would be some effect on genitalia growth if it occurs in pre-pubertal age. Androgen levels would be defective, and there would be symptoms because of an increased synthesis of mineralocorticoids and sometimes hypertension along with it. The same very thing again shown in a different form, that this cortisol mitochondrial going on to pregnenolone, 17-hydroxypregnenolone, and dihydroepiandrosterone. Right? And this pathway progesterone, and this pathway going on to this way, right? So this is the pathway which takes for the aldosterone, and this is the pathway which takes for the glucocorticoid. Now, if you are deficient this enzyme, 17-hydroxy enzymes, it would be converted to this pathway or back to this pathway. So it would be more mineralocorticoid and more androgens being secreted. This is to simplify that which enzyme would lead on to what hormone in excess. So the steroid abnormality congenital hyperplasia, if you have 21 hydroxylase deficiency, the steroid which would be increased would be dihydroepiandrosterone, and this dihydroepiandrosterone would be responsible for virilization or more male type, say, hair pattern in particular in women, which would be increased or decreased. The 17 ketosteroids and 70 ketogenic steroids would be increased. If the enzyme deficiency is 11 hydroxylase, of course, in addition to dehydroepinestrone, there would be 11 deoxycorticosterone would also be produced. So this would lead on to not only virilization but also hypertension. And all 17 hydroxysteroids, 17 ketosteroids, and 17 ketogenic steroids, they would be increased. But when the deficiency is 17 hydroxylase deficiencies, the enzyme that increases 11 deoxycorticosterone, and this would present with hypertension alone, and this level may remain normal or may be decreased, in fact. So this is how we differentiate that which enzyme deficiency predominantly would produce virilization and which would produce hypertension alone. In severe congenital adrenal hyperplasia, which presents at birth, there would be sexual ambiguity or adrenal failure, and patient may present with a collapse or hypotension, hypoglycemia, and sometimes they may be with a excessive salt dosing state like hypotension and hyponatremia. In females, this may lead on to clitoral hypertrophy because of androgen excess, urogenital abnormalities, and alveolo-scrotal fusion, which leads on to that their sex may not be, their phenotype may be difficult to ascertain, and they would be difficult to say gender assignment would be difficult. Milder cases may present in adult life only with primary amenorrhea. In males, that may be lead on to precocious puberty with hirsutism, and presentation usually is late in men. The investigations would include a profile of adrenocortical hormones before and 1 hour after ACTH administration. Basal ACTH level, of course, would be raised because there is a lack of secretion of cortisol, which is a negative feedback for ACTH. 17 hydroxyprogesterone levels were increased, and urinary 17 ketosteroids are also increased. Endosterone dione levels are always raised. The management is that the primary defect is lack of, say, steroids or cortisol. So glucocorticoid replacement at least would lead on to suppression of the ACTH. So usually dexamethasone, large dose at bedtime to suppress ACTH is given. Over replacement would lead on to, say, some further worsening of hypertension. 17 alpha progesterone like testosterone, cortisol, and growth and bone age and blood pressure, electrolytes, and skin osteoporosis scans must be done to monitor the untoward effect of cortisol being administered. There would be a need for correction of salt wasting, so these patients would require 19 alpha fluorocortisone in the dose of 100 to 400 microgram per day to correct their electrolyte abnormality, particularly hyponatremia. Salt supplements would be, say, required again to monitor their hyponatremia, and of course you have to monitor the blood pressure, electrolytes, and edema. The ambiguous genitalia may require corrective surgery to assign gender assignment. Genetic counseling and psychosocial support, of course, is a very, say, important component of their management. A third case is a 34-year-old male who presents in emergency room with complaints of body aches, episodic muscle weakness, numbness, and tingling of the numbs for the last 5 days. His symptoms worsened over 2 days, and he was feeling very painful muscle spasm, or say cramps-like feelings. He also has polyuria and polydipsia, especially at night. He has frequent episodes of headache and palpitation. Last year, he was diagnosed to have hypertension and is currently using beta blocker for control of his hypertension, but blood pressure is not well controlled. On examination, his blood pressure 160 over 100. His pulse was 86 beats per minute. It was regular. Respiration was normal with 18 breaths per minute. There was no peripheral edema. System examination was unremarkable. And laboratory investigation is CBC, liver function test, and renal function test were all normal. The remarkable thing was very low serum potassium and high serum sodium. So hypokalemia and hypernatremia was noticed, and the patient was hypertensive. His urinary potassium was increased to more than 32 millimoles per day. So what's the diagnosis? This is hyperaldosteronism. Now, hyperaldosteronism may also be labeled as primary hyperaldosteronism or a Cohen's syndrome. This results from excessive secretion of aldosterone, and this excessive aldosterone would lead on to increased sodium reabsorption, increased loss of potassium in the urine, increased loss of hydrogen ions, and this would then, of course, lead on to metabolic alkalosis, and these patients would have hypokalemia and hypertension. Usually, the peak incidence of this hyperaldosteronism or Cohen syndrome is between 30 to 60 years of age. Hyperaldosteronism may be primary, autonomous, as in primary adrenal hyperplasia or adrenal carcinoma or adenomas, but sometimes it can be secondary, and this secondary may be associated with renovascular hypertension, cirrhosis, renal producing tumors, and pregnancy. So testing for primary hypertension should be done for all hypertension patients who have hypokalemia. So any patient who has hypertension and hypokalemia should be suspected to have hyperaldosteronism, and their serum aldosterone level should be checked. The symptoms of hyperaldosteronism would be frequent urination, increased thirst, weakness and fatigue, headache, muscle cramps. Sometimes they complain of tingling in the fingers. Sometimes hypokalemia can be worse enough to cause transient paralysis or hypokalemic paralysis, palpitations, and hypertension. The investigations, the first investigation in hypertensive patients who are suspected to have hyperaldosteronism is checking for the potassium level in the serum. And this should be checked without a diuretic. If your patient is already on diuretics for treatment of hypertension, like thiazide diuretics, so the hypokalemia may be diuretic induced, not because of the hyperaldosteronism. Urinary potassium is increased, so there is an increased loss of potassium in the urine, and if it exceeds 30 millimole per day, it confirms that there is more potassium is being excreted and it is not reabsorbed because of the say overaction of the aldosterone. Plasma aldosterone to renin ratio is increased, right? So normally when you have secondary hyperaldosteronism, there is an renin released, and renin leads to an elevation of say aldosterone RAS mechanism, and aldosterone is elevated. So both renin as well as aldosterone would be increased in patient with secondary hyperaldosteronism. But in patient with primary aldosteronism, since there is an increased aldosterone, the renin would be low, so the aldosterone to renin ratio that would be increased. So elevated plasma aldosterone levels, particularly they are not suppressed with the saline. If you give 2 to 4 liters of saline over say 4 hours, you expect the aldosterone level to be decreased, right? But they would not decrease, and similarly fludrocortisone administration would not lead on to decrease in the aldosterone levels. So suppressed plasma renin activity increase the hydroxysterone levels in excess of 100 nanogram per deciliters. Adrenal vein sampling can be done to differentiate the origin of this aldosterone, whether it is from which side it is producing, because serum level will be elevated in both cases. But when you are thinking of operating on these patients, you need to have that which adrenal is responsible for. In that case, you would have a selective blood sample drawn from the respective adrenal veins, and the one which shows an elevated aldosterone in the adrenal vein sample would be the site of origin of this aldosterone. Uh, Postural stimulation test, when you stand from a sitting position, there is a readjustment and there is renin-angiotensin activation, and this would lead on to an increased, say, aldosterone level that would be tested. The imaging or CT abdomen would be helpful in locating the tumors. Primary objective of treatment of hyperaldosteronism or Cone syndrome is to control the blood pressure. Right? Cone syndrome usually is adenoma, and a unilateral aldosterone adenoma would be treated through laparoscopic adrenalectomy. The long-term therapy can be with anti-aldosterone aldosterone antagonist like spironolactone. So aldosterone, or there is another agents which is eplerenone. These two can be used to treat hypertension in these patients. Bilateral adrenal hyperplasia would be, of course, treated with the spironolactone eplerenone, because bilateral adrenalectomy would make your patient say, deficient in other cortisol and other hormone as well. Secondary hyperaldosteronism definitely should be treated with either an angiotensin converting enzyme inhibitors or angiotensin receptor blockers or spironolactone. That's all for the adrenal disorders, and in fact for the all endocrine disorders we have covered, and this will be the last lecture of our session. Thank you.